क्यों नहीं है?
Thank you. Good evening, sir. Good evening to all of you and most welcome. At the start of the session, I would like to thank all of you that you spend all your valuable time and you have come to listen to me. It was great that I was introduced in such a wonderful manner by Dr. Chauhan, and it was a pleasure to meet all the giants of medicine of South Delhi. It's a pleasure, sir. I'm Arun Saroha. I entered MBBS in 1988, and after that, after my MBBS at RMT Medical College, Udaipur, I went to PGI Chandigarh, and there I did my MS and my MCH, and then I came to Delhi in 2002. And those were the days that private practice was not very prevalent, and I was asked to join there as a assistant professor or a part-time teacher there, and I was not liking it, so I came here and met Dr. A.K. Banerjee. Dr. A.K. Banerjee met me for about 15 minutes in Vimhans, and then I was inducted the same day in the next 1 hour. And that is how I worked as a consultant there under him from 2002 to 2006. After 2006, I went to join Dr. D.S. Mehta at Paras because I was called by him, and then as I was staying in Gurgaon, so from 2006 to 2008 I was working with him, and then I joined Artemis Hospital as the head of neurosurgery for the next 5 years. I was the youngest HOD of neurosurgery in NCR then. And after that, I got an offer and call from the management of Max Saket, and so I shifted in 2013 to Max Saket, and it has been about 10 years. I work at Max Saket and Max Gurugram, and I work there on a daily basis. I have teams, my associates, my doctors, my nurses at both the places, and I operate about 50 cases of neurosurgery and spine surgery. I was trained in Singapore and Switzerland for spine and part of brain, and I've been practicing for about 20 years now, and I have operated more than 6,000 spine and brain surgeries, and I operate everything about brain and I operate everything about spine. So if somebody asks me anything, so I would say from craniovertebral junction to the coccyx and from the medulla to the frontal lobe. So that's what my introduction is. And I would like to show you a few things that I have brought to show you, so that you are also elated looking at what neurosurgery and what neurosciences have reached now. There was a time when we all thought that if somebody has a brain tumor, first uska sar mudega aur fir ghar walon ka sar mudega. Many of you have seen those times. So brain tumor was a death sentence. So from there we have moved to a level where you can operate any brain tumor, and you can operate any difficult brain tumor even from the brain stem. And the techniques, the technology, the assistance from the technology has reached to a stage where people walk out. I operated upon a brain stem tumor 5 days back. 5 days back, he was a 30-year-old gentleman. He was admitted as an ependymoma at Max, and I operated, and we came to realize that it was a brainstem tumor. And he walked out, although with support, but he walked out of the hospital today. So that is where the neurosurgery has reached. So every day is a challenge, every day is a different case, and every day we do very different things. Now, I will speak about few things which have come up in the last few years, and you must be aware, you have listened to it, that one of them is awake craniotomy. You must have seen the videos on a lot of WhatsApp groups when the patient is playing a guitar and somebody is operating upon his brain. That is known as awake craniotomy, and I am going to do one tomorrow. To one lady who is about 60 years old, but then she's so strong-headed that she has asked me to do it awake because it is in the area of the left frontal lobe, and it is a perisylvian glioma. So it becomes a challenge where if you start removing it, you can damage a lot of vessels, you can damage a lot of areas, you can damage speech, you can damage hand areas. and that would be the end of the quality of life. And the lady is educated enough and she says, I want the quality of life, whatever. So that is where the neurosurgery has reached, where we do awake craniotomies, we remove the tumors, the patients are shifted to the ICU for a day, they start having coffee the same evening, and then it starts the recovery. Although, as you know, in conferences we always hear such rosy pictures. Everything is not rosy in everything, particularly in trauma. Trauma has yet not reached to that level because it depends on the kind of trauma that the patient has, that how bad or how good it would be. So if a trauma is very severe and you have the rest of the facilities, you may end up having a vegetative patient. But then there are patients of elective, that is why the word elective. In elective neurosurgeries, where the patient comes to you, to your hospital, to your OPD, walking, conscious, then he should go. It is expected that he should go until unless you say that there is a risk to life, which is more than 1%, which is unusual. So usually we say that risk to life is less than 1% and risk of neurological deterioration is 2 to 3%. So it is because of the image-guided neurosurgery, wherein you have image where it is conclusive of it is combined with the MRI, it is combined with the CT pictures, and it leads to you at a correct place so that you have a smaller craniotomy. When you have a smaller craniotomy, the days are gone when we used to open the whole skull. When I was a student then, and there was a small tumor and we used to operate there. Now you have to open on top of the tumor, you have to see how wide the tumor is, and then you have the image guidance which shows you how much tumor is remaining. Particularly in low-grade gliomas, because high-grade gliomas, you do not have that difficulty because high-grade gliomas are different than the normal brain and they can be easily removed because there is a sign where you can understand that the tumor in the brain is different. So there was this public misconception, there were media reports, and there was a competition with cardiac surgery because the cardiac surgery had come much early and then the brain surgery had started coming up little later, as a result of which the neurosurgery was not considered to be that safe, but then it has become now. There was fear in the mind of the public and the medical fraternity, which is going down now. So now, if anybody of us has a relative who has a brain tumor, we don't think about mortality, we think about the disease, we think about the outcomes, we think about the biopsy, and we think about the quality of life. We don't think about the end of the life. So that is where we have changed during the last 20 years, and the change is continuous. Surely, we might not have a situation where it becomes like a cardiac surgery, as safe as, because it is more complex than the cardiac surgery. Because in cardiac things, usually we deal with the vascular system, and it starts and it ends there about 95%. But the brain starts and ends with the solid brain tissue, which is responsible for thousands of functions. And then when you have to remove the tumor, you have to be sure that you remove the correct part of the tumor, the correct part of the thing that you have to remove. You have to be sure that you have left the adequate brain around it, which is functional. You have to be sure that the functionality of a human being is intact, apart from the life. Life is now a distant thing. We don't consider that life has to be saved, because if an elective brain tumor comes and the patient dies, it's a drama. It's a big drama. It has to come to the forum. It has to come to the mortality meet. You have to explain why a walking brain tumor died, whatsoever difficult the brain tumor may be. So neurosurgery has reached there. Neurosurgery is a great field, but I thought to myself that we still know so little about the brain that even after most successful treatment, patient improves just about half. That was said by one of our famous doctors in India. But then that situation has changed. You must have heard and read yesterday that what Elon Musk has done. They have put in an electrode there, and that would, but just by the thought of the human being. So from the hippocampus, that lead would go to that electrode, and so that the patient can talk or do things. So we are reaching to a very different situation, and we will win, and we are winning. We have reached to a stage where we can say that we are good. So this is the picture of the Hindu mythology. The history of Indian neurosurgery goes to the time of Shiva, who had transplanted the head of an elephant onto the body of Ganesha, who was the sun, which seems to be the most challenging neurosurgical procedure. So when we are in Sri Ram mode, so this is one of the wonderful things that you should know about. And modern neurosurgery, as we know it, is considered mainly a development of the 20th century, but trepanation of the skull is undoubtedly the oldest known neurosurgical procedure. After that, we have increased and we have come to a level where we do not use trepines. We use a burr hole and we use a drill. The drill systems are so fine that you can be accurate to the level of half a centimeter of a craniotomy, or 1 centimeter of craniotomy, or 1.5 centimeter of the craniotomy, which you can, if you have the wiseness, then you can do it yourself by seeing the MRI and correlating it with the actual structure. And if you want to use the technology, then you can use the image guided platform, wherein it would say that the tumor starts here, it ends here, and the frontal part is here and the parietal part is here, so that you know you have to open in this area only. Accordingly, you will decide on the incision, and the days are gone when the craniotomies would be large and wide. The surgeon's learning curve, which is applicable to all, and you have to reach the third phase when not to operate, because there are patients who would come that we have been told that the surgery has to be done particularly from periphery, and those surgeries have not to be done. There are many indications where surgeries are not indicated, but they are told in the periphery by doctors. Usually this happens in the cases of arachnoid cysts in the brain. It happens in the cases of disc, because most of the people would read the reports of the MRI, and the reports of the MRI in the spine would say that there is a disc bulge at L4-5 and there is a disc bulge at L5-S1, and you do not realize that the patient is having a back pain, and that back pain is not radiating pain. It is the whole back pain which is going down as fibromyalgia onto the lower limb, and he or she has been diagnosed with a disc and he has been advised for a disc surgery. So we have to be very clear what we are dealing with and how do we do it and what not to operate it. So I come across at least 10 patients, so 5 to 10 patients a day who come for surgeries and who have to be declined, that the surgery has not been indicated. You have come for surgery, but there is no indication of surgery because your MRI is normal. Because if we all go tomorrow to a diagnostic center and we all get our MRIs of the spine, the whole spine or the cervical spine or the lumbar spine, I guarantee you 80% of those spine MRIs would be abnormal, because the radiologist would surely, he has to diagnose it and has to say that there is a bulge, then there is a tear, and then there is a hypertrophy, or there is a neural foramen stenosis or a canal stenosis. Even if the canal stenosis is by 3 millimeter, the radiologist has to define it as a canal stenosis. But then you have to see, if a patient is a 70-year-old man, he is a normal, he just has a back pain, he has just gone for his MRI because he was having back pain for more than 3 months now. So you will have to see whether it is a mechanical back pain or the discogenic back pain. The discogenic back pains are very, very less. The indications of surgery are few, and the surgery indications have to be very, very precise. There are no strict indications where discectomy has to be the main surgery. It can be a discectomy, it can be a foraminotomy, it can be a laminotomy, it can be a laminectomy, it can be a fusion, it can be a dynamic fixation. So there are many, many techniques which have come into the play, and we should know, we have to be in the correct place with the correct advice so that we can choose, because the science has to be known, because the science is not perfectly known by all, and the understanding of the science and the technology has to be in sync. And when it is both there with any surgeon, any doctor, anybody of us, then obviously that doctor can decide in a better manner as compared to what anybody else would. So this was a tumor. This is the pre-op. This is a cystic tumor removed. This is the post-op MRI. Now there is an MRI which shows that there is a craniovertebral junction tumor, which is a meningioma. As you can see, it is adhered here. The patient came with quadriparesis on a wheelchair, and this is the MRI after a year, and the patient is walking. This is the tumor in the fourth ventricle, this is the pre-op, and this is the post-op. This is the tumor in the brain stem, as you can see. This is the pre-op and this is the post-op, and it is going, just informing the thalamus. The patient has hemiparesis, but then the patient lives. A large tumor in the posterior fossa, operated, this is the post-op MRI. A large meningioma, tentorial meningioma, falci meningioma, faciotentorial meningioma, that is what we say, this is the post-op MRI. This is a large tumor coming out of the choroid plexus, and it was a highly vascular tumor, as you can see, and the post-op MRI shows that there is no tumor. Pre-operative MRI, this is a lateral ventricular tumor, and this is a post-op MRI, there is no tumor. This is a low-grade glioma of the motor cortex. Motor cortex, this is the leg area because this is the most medial one. This is the pre-op and this is the post-op. This is the aneurysm which was spoiled, which was clipped, and you can see the clip, and the patient was fine. Similarly, this aneurysm was also clipped, and this is the pre-op and the post-op image. Pre-op and the post-op image. Large tumor in the posterior fossa, the image quality is very poor, you cannot see it, and it was removed completely. A large meningioma of the sphenoid, which was removed completely, and this is the post-op MRI. There are many more which can say that, but I don't want to waste your time in seeing all this, and tell you some few more things. So I was saying you about the arachnoid cyst. This is a cyst which is seen, and the patient will present you as a headache. How many patients of headache do you send for MRI? Hardly 20% or 10% because they keep on coming and they don't improve. You have treated for migraine, you have treated for complex headaches, but then they still keep on coming. And then it would be reported as arachnoid cyst, and then usually it would be said, the report would be saying that this is a splayed thing and the cortex is compressed. So the people would say no, it is to be operated. Usually such patients would come from periphery and then they have not to be operated. Similarly, this thing, non-progressive asymptomatic lesion lying there, the MRI was done for a certain reason, it was an accidental finding, you need not operate. Now, there are many other ways to treat patients. So this you can see is a large pituitary tumor. But then this large pituitary tumor was basically a prolactinoma. So the patient was asked to go for surgery, the prolactin was never asked, and it was 4,500. The patient was put on the drug, and this is the post-op MRI, as you can see. So these are the lesions which are not to be operated. The location and the size of the tumors are also important. If this is a CP angle tumor, the patient comes to you with tinnitus and you operate this tumor, you will send the patient with a facial palsy, you will send the patient with deafness, you will do everything. So what is the treatment for this? Ideal treatment is gamma knife, but gamma knife nowadays is not available in private, it is only available at Cmes. So cyber knife or image guided stereotactic radiation is the choice for such patients, and they should be only given that, not never operated upon. So this is one of the images of coiling where there was a basilar top aneurysm, and if you operate this aneurysm, the complication rates are high, the morbidity is high, the hospital stay is high, eventually the patient would lose the quality of life. So the easier treatment is the coiling, and it has become the treatment of choice in aneurysms and arteriovenous malformations recently, and it is growing by the day, not by the months and years, and it is going to be the future of arteriovenous malformations. So the surgery has to go out of this unless there are some few indications which are not more than 5 to 10% which would eventually need a surgery. So this is a large tumor. If the patient presents to you and comes to you at M2 state means a very comatose state and deeply unconscious, what are you going to achieve out of it? when the patient has a very diffuse glioma, it's a brainstem glioma, if you operate, you are only going to do more damage. Similarly, a large lesion here, if you operate, you will lose the patient. It is similar to chasing an outgoing ball by a cricketer and is caught behind the wicket, realizing afterwards he should not have done it. Similarly, neurosurgeons should learn when to stop. So that is where, and that is what we need to learn in neurosurgery, when to stop and why to stop. Lights please for some time, and I'll come back with a few more images soon.
Lights.
It was not for you when to stop, sir.
Sir, do you want the lights on, sir?
Yeah, so that everybody is comfortable till I come up with. Okay.
No, that's not a problem, sir. We'll wait. Wonderful presentation.
No. So, what is new in spine surgery which is available? We must all be hearing about it, that robots are there and robots are helping us and robots do guide us. So, robot in spine surgery is going to come in Max Saket. It has been added to some institutions of Max but not to Saket yet. It will come soon. Apart from robot, you need a O-arm. What is an O-arm? The technology is just you double it, double the C-arm. So there are two C-arms and it is also digitalized. And it is all digitalized, and when what you do is a patient lies down on the table prone after the anesthesia, you go with the O-arm, you take all the images, and all those images are stacked in the computer in front of you on the screen. Now that will guide along with the guided image that how and which angle to take in, so that you don't put your screw in a wrong place, so that you put the correct size of the screw, so that you do not break the cortex of the bone, so that you also see that the alignment is right, so that you also see that the cage is right, and the listhesis, that is the abnormal alignment of the vertebral bodies also become more aligned. Then there are spinal vascular cases which are pure neurosurgery. I will show maybe one or two to you. So this patient comes to us with spasticity, has been diagnosed with a disc problem. But it is clear that the patient with a disc problem in the lumbar spine would have pain in the lower limbs, would not have spasticity, would not have difficulty in walking, because the science does not go wrong, but he has been diagnosed. He has a L45P IVD. The patient comes to us, 40-year-old man. You have to search for the upper motor signs in the lower limbs. So we do the whole MRI, then we still are lost. We do a contrast MRI. We see a large AVM sitting in the dorsal area, and the dorsal spine. So what was it doing? That AV fistula was taking away all the flow directly from the artery into the larger vein and not supplying the spine, as a result of which the spine had developed myelomalacia. So that is a damage that has happened to the spine. Until you repair that or do something, the weakness in the lower limbs will not get better. So we did, and as you can see, there is a dural AV fistula, as you can see, which has been pointed here, and then I hope the video works. Yeah. So, hot water. So, as you can see here, there is this abnormal blood vessel coming from the dura, and this is the cord. You are separating the cord. This is the arachnoid from the arachnoid, and you can see this abnormal vessel. So the whole vessel, the vein has been arterialized. The vein has been arterialized. The vein which would have been a 2 mm vein is now a 8 mm vein, because there is a fistula between the artery of the dura and the vein of the cord, as a result of which the blood supply which was supposed to go to this cord has been taken away. So what you do, you put a clip or you do a embolization or coiling. You do embolization. Embolization can be risky in AV fistulas, particularly when the AV fistula is a high flow fistula. A high flow fistula, you put in a coil, it just flows out and it can go to some other place. So they become dangerous to do. So in this, we clip this we did the imaging. As you can see, we did the imaging on the table, and you can see the whole flow. This is the whole flow going in, and I put the clip here so that I was sure that this vessel was responsible. This went away, and now see the angiography. Post clipping, there is no abnormal flow of the blood. So all this technology is available, and we can do good to the patients, correct to the patients, and we can prove it to the patients if the patients wants. At times you might just not get. We come across, there is a cyst around the nerve root, there is a cyst in the sacrum, and you have back pain, and the reason is this Tarlov cyst. So these are the cysts, and you have to see and you have to decide whether you should operate or not, until and unless such a cyst is giving rise to a lot of compression, and if this cyst is going, this will not give rise to back pain. This will only give rise to the involvement of bladder and bowel, because the nerve root to the leg has gone, the last nerve root has gone from here. Okay? So the patient is walking normally, but the bladder bowel is involved. So this is the case where you have to operate.
Hello.
This was the case of fracture which we operated upon by doing a minimal invasive spine surgery, because the height of the vertebra was too small to do a kyphoplasty. Similarly, a craniovertebral junction anomaly where the C2 is very enlarged and goes into the brain has been cut transorally. We go transorally in this through the mouth, and we cut this, and the patient gets repaired gradually. Similarly here, the post-op image, we do it posteriorly. Why do we do it posteriorly? Because we can push it, the dents, to this place. It is not too big. If it was too big, we could have done transorally and removed it. Now this one was pushed anteriorly so that the space was enough for the cord to pass. This is another way of fixing the craniovertebral junction, which is a C1, C2 fusion. Intrathoracic tumor coming into the spine and giving rise to the image was not correct. It is not important. Yeah, so IDM. IDM is intradural extramedullary. So it is outside the cord, but it is inside the dura. It's a neurofibroma. Classical picture of a neurofibroma, operated, removed, and there is a post-op MRI. There has been some damage, which is a residual damage. Fracture spine, operated in parts, multiple disc degenerations. Anteriorly you can do up to 3 maximum, but usually you should not do more than 2. If there are multiple levels where the degenerations and the compressions are multiple from anterior, you have to go from behind, and when you go from behind, if you think that the mobility is too much, then you fix the spine through the screws, with the use of screws. Now, this is the case where he was a young patient where he came to us with myelopathy. You can see that there is a damage to the cord, but the patient was young, so we chose that we do a disc replacement rather than a fusion. So that you have to decide which patient, what body weight, what are the problems. There is a osteopenia or osteoporosis. If the patient is old, you cannot do that. If the degeneration is significant, if the osteophyte productions or the osteophytes happening there around the area is too much, then you cannot do disc replacement. So the spine has to be healthy except the disc, then you do disc replacements. This was one of the challenging cases. When we do such kyphosis, usually these patients come after years old tuberculosis or trauma, but they could still continue to walk, and then they would come because they are now deteriorating because this is pulling. Now there is a stretching injury to the cord. So what do? You use nerve root monitoring. Nerve root monitoring means neuro monitoring on the lower limbs, because when you are operating and you are correcting the curvature, you might just injure the cord or the nerves further, leading to the deterioration of the patient. If you are using neuro monitoring, then the chances of that happening is little, and you can just straighten the spine by fixing it and fusing it. Fracture, remove. Then there is another way of fixing fracture. C2 fractures are very common. So this is the way that we fix it, except that for type 3, which was shown in the last one, that was type 3. This one was type 3. This type 1 or type 2, if they are around the base, then we put the screw through a small hole here, and it goes up and it catches. It is so manufactured the way that it is made. Now, as you can see, that this patient had come with a lot of back pain, but at the same time there was compression, and the patient was 84 years. I didn't want to fuse it. So what I have done is, I have kept the ligament straight, intact. The interspinous ligament is intact, the spinous processes are intact. So we made small holes. So laminotomies were made so big, and did foraminotomies, so that his radicular pain goes away, and at the same time his back is preserved without fusion. Thank you very much.
Friends, all of you would agree that we had a wonderful presentation by Dr. Arun Saroha. Yeah. It was a big applause. Since I think practically he is doing everything. My first question to Dr. Arun Saroha sir is, sir, what is it that you are not doing in neurosurgery?
There are many things. I do not do gamma knife. I do not do cyber knife. I do not do cyber knife. I do not do gamma knife. I do not do radio intervention. So तीन चीजें तो मैं ले ही गया ना. So सिर्फ सर्जरी कर लेते हैं, और सर्जरी कर लेते हैं ब्रेन की और स्पाइन की सर.
Sir, you mentioned that there is a case which had to be operated by gamma knife, but unfortunately you didn't have a gamma knife. It was available only in names. What is the difference between gamma knife and cyber knife, just for the lesser mortals?
So there are technical studies. There are many studies which are available which say that the gamma knife and the cyber knife effective. They are equally effective. But the people who do gamma knife, they would present us in the conferences some data where they would find a difference of 1% where the gamma knife is better. Sorry, this gamma knife is practically not possible because it is very costly and it can act only on brain. Cyber knife at the same time, with nearly the same cost, can do the treatment of the cervical spine and the other parts of the body. So everybody is putting in cyber knife, and cyber knife results. I would say it was gamma knife was considered to be the gold standard, but now the cyber knife would take its place, but it would need its own time, 5 to 10 years again. But it is equally effective. It is equally effective.
You showed us many cases, sir, and we know that one of the worst tumors which affects brain is glioblastoma. Not many cases that you showed here, sir.
Because gliomas are very common cases, and they are done left, right, center, and every day there is a glioblastoma happening. There is not a good story attached to glioblastoma, so they are not presented. In my 23 years of practice, I have seen only one GBM surviving more than 10 years. We have not seen, because they don't survive.
What is the usual survival of a glioblastoma?
It can range from 6 months to 3 years. With best of the treatment. With best of the treatment.
Right, sir.
Yeah.
Sir, I wanted to ask you about the prognosis of glioblastomas in the brainstem area.
So glioblastomas do not occur in brainstem areas. Brainstem tumors are usually low-grade gliomas. They are grade 2 gliomas usually. And then if either, like in the last case that I did 5, 6, 7 days back, I could remove it completely. So I'll do an MRI after 3 months, and if there is no residual, we don't want any radiotherapy. But if suppose there are some cases where they are not so well defined and you have to leave a part of it, then you can go in with any kind of radiotherapy. Not a standard, but an image guided radiotherapy.
Sir, I wanted to ask you, we keep hearing about internal carotid artery occlusions, external carotid artery occlusions, and then occlusions deep inside the brain. And there are a lot of people who say that stenting versus endarterectomies. You didn't show anything of that.
Because I don't do it, that is why I didn't show it. But then if you ask me personally, then endarterectomies are obsolete. They should be only done if they are, 90% occlusion, 95% occlusion. The thrombus is very big. That fat thing, cholesterol thing is too big. Then, and if the angioplasty fails, that is another indication. Because if you put a stent and if it is not expanding, then you have to do something. Then endarterectomy comes into the picture.
Sir, suppose I have a case of post-circulation stroke, and I know that it is because of vertebral artery dissection. Can I refer that case to you, or there is somebody else in Cmes where I should refer that case?
So the neurosurgery and the neurology team works in tandem, and there are 4 neurologists and there are 4 neurosurgeons. I'm talking about very senior ones, directors and above. And apart from the 15 to 20 doctors team that we have. So the patient comes, the patient is seen in the emergency. Suppose if the patient comes to me, I'll immediately refer the patient to the concerned person, and then that patient can be taken care of by the neurointervention guy. The patients are usually technically and medico-legally not admitted under neurointervention people. They are either admitted under a neurologist or a neurosurgeon.
Sir, do you have an intervention guy?
24 hours.
In Cmes?
24 hours.
All right. And
A flat panel lab.
And are you doing these interventions on a regular basis?
Very regular basis.
On a regular basis.
Very regular basis.
Right. Sir, you showed some cases of aneurysms.
Ji.
Are you doing it, or the neurointervention guy is doing it?
So, as I told you, that it is being taken over by the neurointervention guys, because now nobody wants, if you give an option to the patient that 4 to 5 lakh would be the expenditure, one option is to open the skull and it is an MC aneurysm, you do it, there will be no complication. And then the other option is that, you do it angioplastic kind of a thing. Who would want that cut to be done? So nobody wants. So eventually they go. So unless the neurointervention guy says that it would not be possible by intervention, the patient is not convinced about surgery anymore.
So you said, from a wide experience of yours, that glioblastomas still have a very poor prognosis. You don't want to talk about it because it's a sad story to tell. I wanted to know which tumor has improved prognostically over the years that you've been practicing.
Most in the knee.
Like, sir?
It can range from neurofibroma to a low-grade tumor, low-grade glioma, to meningiomas, to anything. Everything has gotten better, but the GBM we do not have answers to.
Right.
People have been trying, the chemo has been extended by a few more drugs, but then nobody has a clear-cut answer. People have done surgeries, redo surgeries in gliomas, and they have put some specific chemicals into the cavity, which are available at an exorbitant cost of 10 to 15 lakh rupees, which is to be put there, chips carrying radiotherapy in it, but then the results have not been good.
Yes, Dr. Podar, sir.
So, Dr. Saroha, in the patient you did operate for neurofibroma and then did radiotherapy also for extracurricular part. So, can we try only radiotherapy if patient doesn't want surgery?
If the tumor is not compressing upon the nerve, if it is not compressing upon the brainstem, you can go ahead with radiotherapy.
No, if it is compressing, then...
If it is compressing, then the role of radiotherapy is minimal, but the patient can still choose to take it as a therapy. That okay, I might have a problem in the brainstem, I might have a problem in the walking, but I don't want to cut, fine. I don't want to open surgery. But technically, there is a rule in CT angles, if it is more than 2.5 to 3 centimeters in size, in any one dimension, there is no indication of radiosurgery or radiotherapy.
So why gamma knife is not available in private sector? It only cost? Or
It is a cost, and because it is not viable. How many people would you put in, if you get 10 neurosurgeons together and they put a gamma knife, that still is not viable. People do talk in conferences after having 4 drinks. That can we do that? But it still is not possible. It is not viable. People have failed, the centers have failed. We have two failed stories. One was women's and another was in the
Yeah, that my next question was
so,
demands,
but at the same time, I'm saying is that if cyber knife is equally effective, why do you need the gamma knife?
So last question, in the case of AV malformation, you must have clipped the artery.
The fistula, the communication between that abnormal communication from the artery to the vein.
So
that fistula.
Near the artery.
Yeah.
So thank you. Thank you.
Sir, we have Dr. Bhantu Shukla. He is a DM Neuro.
Hi, sir.
He is in PSRI.
Yeah.
He likes to ask a question.
Sir, very nice presentation.
Thank you.
You told that a good surgeon, a good neurosurgeon is one who knows when not to operate. So absolutely true. And you showed us examples also. So it's more like comment rather than a question. I recently had one case. He was a child. He was 4 years old and he had epilepsy and which was poorly controlled with medication. So I reviewed.
Did you find a lesion in the MRI?
Yes, sir. I saw the scans. There was a lesion which was hyperintense on T2 and flare, left temporal area, and it was reported as DNET. So what are
It was a generalized or a focal epilepsy?
So it was a focal with secondary generalization.
Focal with secondary generalization, if the cause was that, you can easily go to a left temporal lobotomy.
Yes, sir.
There is no question about it.
Yes.
So as long as you are removing a part of the brain which is not important, so you can do either in left, even for that matter right.
Left
That is
temporal
the
lobectomy.
yeah.
Anterior temporal lobe.
And he means he wants to say that don't go to the hippocampus and don't remove the medial part of the spinal, which does happen many a times in the initial ages.
But my one question is here.
So,
In cyber knife, we use stereotactic method to treat the radio material. We are putting the radio material to the tumor.
yes sir.
So what is same thing in the gamma knife also? We are
Same thing in the gamma
So
knife,
what
same
is
thing
the
in the gamma
difference,
knife. It is a source of radiation which is different, sir.
the source of radiation.
Yeah.
Dr. Kanru sir, I'll come to you, sir. Please wait for your turn, sir. Dr. Alaparashar.
Sir.
Sir, very nice presentation.
Thank you, sir.
I'm an ENT specialist. I have a small comment to make and then of course a question. Comment is that yes, your point about the patient walking away on the 5th day of surgery is very welcome. In fact, we have come a long way. I remember one of my colleague, she had her mother-in-law who was operated in somewhere in US, and they were very happy that it was transcranial pituitary surgery. And they next day morning, doctor came and made the patient sit up in the bed and said, "You can have your meals." This was a wonderful thing in 1986 when we were in LNDP. Now come to this that since about 2012 or so, we have been doing pituitary surgeries and we make the patient go home the same day also. So that is how far we have come across as far as the morbidity and mortality after surgery.
Sir, if your endoscopic dissection
Yes, sir.
and your hemostasis is good, you don't need to keep the patient more than 24 hours.
Very good.
It is as simple as that.
So,
But like I do it with the microscope. I don't take the help of ENT because he'll take a little more money.
please do, sir.
So,
Or you don't believe
so when we are in a hurry and we have to finish that pituitary tumor within an hour, so we ensure that the patient has a coffee on the same evening, has done lunch and breakfast the next day. But because we want to keep the packs for 3 days, we want to keep the patient there. But the patient is roaming around in the corridors.
Anyway, sir, I am at Apollo Spectra where we have a short stay surgery. So we send the patient home, comes back in 2 days time, we remove the patient.
That is very much possible. Yeah.
So, other thing is I just want to know more about the other endoscopic surgeries we are doing for the brain. Across critical rate, across wherever you can go into the brain. So what are the things you have somehow not connected? Please tell us.
So I don't do endoscopic surgeries per
Or
se.
anyone
There was a person previously who was doing it, and I have not come across as a neurosurgeon who is doing it very routinely in most of the surgeries, except I've heard a couple of them. So let me see, I might have somebody who will join me with doing these endoscopic scans.
Done only by ENT, mostly by ENT.
No, we don't. ENT surgeries, people who are not very deft with doing TNTs themselves, they would ask the ENT surgeon to go there and open the cellar. But they would do it more neatly and cleanly because they can see everything. As per what I can see something which is lying there and I'm seeing here, and at the same time the eye and that your hemostasis may not be that good. Your dissection may be more gross as compared to a ENT doctor.
Sir, we want to have a peer-reviewed question.
Yes, sir.
We have Dr. Amitabh Gupta. He is a neurosurgeon in PSRI and you know him.
Yes, sir.
He will have a question.
No, first of all, I will compliment Dr. Saroha. He is an excellent surgeon and one of the best in New Delhi. I agree with whatever he has said, but yes, with Dr. Parashar, I agree that there are advances in endoscopic and there has been a lot of advances, and there are few persons who have revolutionized the whole of the endoscopy, what you call as 360-degree brain. So functionally you can do it, it's possible. The only thing is that you need the gadgets, and yes, I compliment Dr. Saroha because he has always told that you should know where to stop and where not to operate. So that is the first thing a surgeon should know, whether his expertise is there or not. So if the expertise is there, you should go ahead. There is no doubt about it, and he is a very expert surgeon in whatever the field he is doing. But the other thing, as the things are there, endoscopy has come a long way, and definitely the amount of imaging, amount of gadgetry it is there, it is being made more and more comfortable. I do everything endoscopically, whether it is intraventricular tumor, whether it is endoscopic TNTS. But I still agree with Dr. Saroha that certain tumors are equally or maybe even better with microvascular or microscopic approach as a large pituitary adenoma. But even those have been shown as to have a good outcome. When coming back to the gamma knife and cyber knife controversy, if you ask me, there are around 200 centers in US of gamma knife as compared to cyber knife. So cyber knife has been developed for whole over the body. The gamma knife, I am trained on gamma knife. So the thing is, the gamma knife is only precisely for brain and maximally to the upper cervical junction. The reason I am saying this is it delivers, as he told, it is all about the kind of radiation it gives. It's cobalt 60, which has got a half-life of 5.5 years, and after 5.5 years you have to change the source of that cobalt. So it's a very costly affair. It's a very, very costly affair, and as he said correctly, there are very few centers which are viable enough to do that. So very true, and cyber knife is equally and well efficient in tackling this. Even the what you call the linear accelerator, the line, if it has got that capability, it is good enough. So I think Dr. Saroha has given you a comprehensive review of all the kind of neurosurgery, whether it is brain or spine, and I really appreciate the way he has took you along to the kind of tumors he can deal with, the kind of pathology he can deal with. He is really a kind of a champ with that. I compliment him. Thank you.
Thank you.
Sir, before I give it to the masters, a question which is very close to my heart. Do you have a role in treating epilepsy?
Yeah, very much.
What type of epilepsy are you treating surgically?
Surgically. So as what he was saying, so that any epilepsy which is coming out of a lesion, वो डीनेट हो, बीनेट हो, कोई abnormal lesion हो, कोई scarring हो, whatever it is, so you can remove that and help epilepsy. if there is a mesial temporal sclerosis, and that is the cause of generalized epilepsy, you should do that. So these are the very clear-cut cases. Now there are few more cases where they need multiple drugs and still not controlled. In that, the newer modalities are coming in where we put electrodes on top of the cortex and we do it, but then I have not done it, so I cannot say much.
Right, sir. Sir, may look like a foolish question, but I wanted to ask you, sir. Any role of cerebral tumors in causing epilepsy?
No.
And no. So absolutely, cerebellum has got no.
No, sir.
Right, sir. Somebody was asking me, asking it on behalf of somebody. Are you doing brain stimulation also in
Yes, sir.
Parkinson's?
Yes, sir.
What is the cutoff age?
Cut-off age means you want...
You don't want to do it beyond that age. It won't benefit.
No, it would benefit all the ages. It would depend. If the life expectancy of a patient is 5 years or less, then it becomes a problem.
Can you do it at the age of 85 years if the patient is otherwise healthy?
Yes, and if the patient wants, yeah.
What is the cost in your setup, sir?
It's about 30 lakh rupees.
Now, for the DBS.
Yes, sir.
Right, sir. And will the other medications will be then off?
Sorry, $30,000, I'm wrong here. 23 lakh.
23. The other medication, the multiple medications patient has been taken, will they be taken care of or he will still
So,
have to take
if a patient is on 5 drug therapy and has a lot of side effects because of the Parkinson's treatment, then the drug number can come down and the side effect profile of the drugs and the dose would come down too.
Alright. Sir, to the master. Dr. Tulsi, sir.
No master at all, Dr. Chuan. So after those wonderful questions, Dr. Arun, let me first compliment you on doing more than 6,000, brain and spinal surgeries and aiming at zero mortality in neurosurgery. That's
You said near zero.
yeah, very commendable.
Aim to वही है.
So, Dr. So, with the advent of real-time MRIs, artificial intelligence as well, and advanced neuroimaging, I'm talking about the IBS, which is the intraoperative brain imaging system, and the Cmes, which is the image-guided neurosurgery, which play a critical role in complex neurological interventions as you do. So talk us through the, the neuro imaging, which have played a crucial role in your neurointervention.
So deep brain stimulation is one.
No, sir. I'm talking about artificial intelligence with the advent of real-time MRIs and the Cmes and the IBS. So these are newer imaging modalities, probably,
We used to have an MRI, intraoperative MRI, but because it was such a lack of use of that MRI, we removed it and we have replaced it with an intraoperative CT.
right.
Now we have an intraoperative CT and we have a stereotactic guidance monitoring. That when we use a stereotactic guidance monitoring, that is combined with the imaging of the MRI which has been done downstairs in the MRI, but it is still in the system. So when these two things are being used together, then your accuracy to find smaller lesions, to go to very critical structures, it becomes more precise and perfect.
Dr. John talked about, the context of temporal lobe epilepsy as the most prevalent surgical, remedial measure and pharmacoresistant. So, probably, performance of artificial intelligence here is better to the extent of 96% success rate as compared to 66% with neurosurgeons. Talk us through this, sir. The artificial intelligence.
So artificial intelligence is concerned, I am a student of AI as you are. I cannot comment on that.
Wonderful, sir. Okay, sir. So, Dr. Chauhan also talked. Where is Dr. Chauhan?
I'm there, sir.
Anyway, let me proceed. So, he talked about the most aggressive, primary intracranial tumor, which is the GB. This is the glioblastoma, which are previously known
GBM. One of our very esteemed friends' wife had GBM, and she barely survived for about 8 to 10 months. It's a temporal diagnosis. See, are there some certain, molecules or immunotherapy? I'm talking probably about the CTLA4 blocker, which seems to have some effects on the GB.
So those chips are put in the recurrent GBM, and I myself have done about 5 of them, and the cost is exorbitant, it's about 10 lakh rupees, and then you put it, but still you will get a recurrence within the next few months to maybe a year. So it depends where does the patient come from, which area of the brain he has. Suppose it is a temporal glioblastoma multiforme, the patient can afford it, I would surely want to do it.
Great. So you said that probably would prolong life.
Yeah.
Maybe for a few months.
Maybe for a few months to a year.
Right. So what is the maximum time which
Patient living for 40 years.
Yes.
Yeah. But then these things are very, very rare.
Yes, indeed. So talk us a little about the EVT, which may be safe and associated with favorable outcomes even beyond 24 hours. See, till now we knew that between 6 to 24 hours, if you do an EVT, probably the patient outcomes are good. But now we are talking about EVT beyond 24 hours after an ischemic stroke. Talk us through this, sir.
So I do not deal with ischemic stroke with neurologists.
No, sir. I'm talking about endovascular therapy.
That's what I'm saying.
Thrombectomies.
No. Thrombectomies. The role of neurosurgery in infarct is very simple. If there is a MCA complete infarct, if there is a complete infarct and half the brain is dead, and then it is causing the deterioration in the neurological function and the consciousness, then my role comes in as a decompressive brain only. Nothing another.
Okay.
And make it open so that there is more space and the patient can survive. It doesn't improve the quality of life, it improves the life.
Right. So my last question would be regarding the FUSA.
Yeah.
This is the focused ultrasound ablation in PD.
Yeah.
It's targeting the globus pallidus internus or the US pallidotomy, which is very safe and non-invasive as compared to DBS. What is the success rate of the focused or the...
So that those surgeries are long being obsolete.
Yeah.
We do DBS for PD, no surgeries for PD anymore. As far as CUSA is concerned, CUSA is being used for most of the surgeries nowadays. I would say maybe nearly 90% of the surgeries they use CUSA as far as tumors are concerned, or any solid organ problem there. And
I'm referring to the PD and tremors.
So that I'm here, it is not equivalent to PD anymore. No role of surgery in PD. It is only deep brain stimulation. However severe it may be.
Thank you, sir.
Sir, I'm very elated to be the last of the train. And my younger brother speaking so highly on a very, very sophisticated topic. I've reduced my questions to minimum because my other friends have asked, they have stolen my questions. Sir, you talked about Lord Ganesha. So I think it was the first total body transplant.
Total head transplant.
Body transplant, head and body बदल दिया, head बदल दिया. So it is TBT, genotype, not the same. Sir, that was wonderful, and we adore our Lord Shiva for that surgery. Dr. Chauhan has also asked about epilepsy and surgery. What about neurocystis or neurosis? Are you doing some surgery there?
So there is no indication of surgery in neurocystic necrosis.
If it is causing epilepsy?
Even if it is causing epilepsy, if the epilepsy is controlled by 2 to 3 drugs, there is no indication to remove the cystic surface. Why? Cystic surface is hardly, it is a sub-centimeter lesion, 3 millimeter to 4 millimeter or 2 millimeter. Now if you remove it, if you remove it, then you will still leave a scar there. If you leave a scar there, the chances of that scar giving rise to epilepsy is equal to having a neurosis circus. So there is no indication of surgery in neurosis circus. There is only one indication of surgery in neurosis circus, which I had seen about 10 years back, single case seen by me in 30 years. That was multiple neurocystic circus. There were more than 100 in the brain, and they used to have repeated inserts. So the raised ICP was so much, the patient had already gone blind, so we did a radiography to increase the life.
Dear friends, my last attention to the imagination. You said C1, C2 junction you use for the benefit. So, can you prevent atlantoaxial subluxation due to hanging if it is planned?
If it is planned,
yeah, one is going to hang. Can you fix that area?
Yes, you can do C1, C2 fixation.
No, atlantoaxial, it is atlantoaxial joint that will be causing that will hang patient. I am saying because one of the patient, one of the clients of Motilal Nehru, he got spot free because he was, when he started hanging, he said stop it. Then it was not written till then. Then he said, we have not written till then. We have said hanging and it is hanging. So I am saying if you are fusing the areas, can you fuse that atlantoaxial joint and the person will not die even if hanging?
The person should not die, but the weight of the body is around 70 kg. That weight suddenly falling from a height, that whole volume of the load coming onto that area, the screws may not survive.
So maybe we may have to improve to elaborate and escape hanging. Sir, osteoporosis is one of the concerns. Is fluorosis also a point?
Fluorosis has a problem in spine. It causes two things. It gives rise to a brittle spine. It becomes hard, but it becomes brittle. Secondly, it can lead to very hard bones where if you do want to do a fusion or fixation, it becomes really difficult.
So Dr. M.S. Gandhi has a question.
Is there any role of surgery in epilepsy caused by tuberculoma?
Only if the tuberculoma is not being treated and it is still growing, in spite of your anti-tubercular treatment, then there is a role of surgery, otherwise no.